Hello, everyone. My name is Robbie Stern, and I am the president of the Pizarra Education Fund. I want to thank all of you for being here. We think we have a wonderful webinar prepared for you, and we want to thank you for coming and supporting the work to reclaim Medicare from the greedy profiteers. The Pizarra Education Fund is the 501c3 arm of Pizarra, and we publish our monthly 12-page newsletter, The Retiree Advocate. That is the responsibility of the Education Fund. You can view that newsletter at our website. That's at pizarra.org. If you like it, you can receive it monthly electronically in hard copy or both. Hard copy and electronically. You'd get the hard copy in the mail for only $20 per year. And by doing that, you also support the work of Pizarra. You can join on our website. Pizarra, Puget Sound Advocates for Retirement Action, is an organization with approximately 1,400 members and has been around in different iterations for approximately 45 years. It is multiracial, multi-generational, and we have members throughout Washington, with the majority in the Puget Sound region. And we have a growing number of members from other states. We lead the fight in Washington for the preservation and expansion of Social Security and traditional public Medicare. We feel that we very much want traditional public Medicare to be as affordable as the private insurance option, what's misnomered Medicare Advantage, and we're working hard to make that happen. We are also very active on issues of racial justice, led by our Race and Gender Equity Committee, issues of environmental justice, and countering climate change, and advocating for progressive policies nationally, in our state, and locally. Before I introduce our presenter for this webinar, I want to let you all know that we anticipate you will have questions. At the bottom of your Zoom screen is something called Q&A. That is where you must put your questions for Dr. Weisbart after he does his presentation. The questions will be received and will be answered after the presentation. Dr. Weisbart, Ed Weisbart, is the National Board Secretary and Missouri Chapter Chair of Physicians for a National Health Program. PNHP is a nonprofit, nonpartisan organization of more than 25,000 physicians and other healthcare advocates in support of publicly financed, nonprofit, single-payer national health insurance program that would fully cover medical care for all Americans. Ed is a national leader of PNHP and chairs PNHP's Anti-Medicare Privatization Steering Committee. He also serves as president of Consumers Council of Missouri, a nonprofit organization that works to build more inclusive and equitable community through advocacy, coalition building, collaboration, and community education. After practicing family medicine for 20 years at Rush Medical Center in Chicago, Dr. Weisbart moved to St. Louis in 2013 to serve as Chief Medical Officer of Express Scripts until retiring in 2010. He worked as an assistant professor of clinical medicine at Washington University in St. Louis, Missouri from 2004 until retiring in 2021. Ed is a wonderful human being and a great teacher, and we are very pleased to welcome him back to our educational campaign to better understand the threat to Medicare so we can develop a good strategy to stop and drive back the corporate takeover of Medicare. Once again, thank you for being here. Don't forget to use the Q&A function at the bottom of your screen to ask questions. Ed, take it away.
Thanks, Robbie. Thanks, Pizarra. I always love talking to all you folks. You wind up pushing me to do something a little bit further ahead than where I am, and so I love that. Tonight's talk is just like that. Some of you may have seen me talk for Passara a couple of other times, and there will be a little bit of overlap, but because of Passara being on the cutting edge of so many things, indeed, a lot of what we'll be talking about, you'll be the first group to see. So this is some new information, and thank you for that, because then now I have new slides that I'll use for other groups too. So one of the many reasons I like that, I'm just so impressed with some of the work that Passara does. So let me get my slides up here for you. Oop, 1 second. There we go. There, you should be able to see my slides. If you can't, let me know. Okay, so you heard the topic from Robbie. We're going to spend a fair amount of our time sort of trying to demystify and simplify this seemingly Byzantine mess of what is Medicare, what's Medicare Advantage, what's Medigap, and how do you decide what you want to do as an individual, and what should the country do? So we'll try to unpack that a bit. Let me be really clear. We'll be talking about some policy issues about Medicare Advantage. But we'll also be making it clear that individuals facing the choice of what to do with their personal health care plan, it's really a decision. I'm going to show you some flaws with Medicare Advantage that I'm not sure everybody fully appreciates. But that's not a request that everybody has to run away from it. I'm going to show you choices. I'm going to show you how you would make the trade-off, and we'll try to talk through it, because it's really an important decision. It's an important decision for somebody nearing age 65. It's an important decision for somebody past age 65 who's already in Medicare and seeing all the ads on television trying to persuade them to alter how they approach their healthcare finance. And it's an important topic for somebody significantly younger than that, who has family members also in the program. So I heard Uwe Reinhardt, a healthcare futurist, once before he passed away, thank you, talk about how to select a health plan in America. And I've sort of customized what he said a little bit because I thought it really resonated. So I made this how to select a Medicare Advantage, so to speak. It's not really an advantage. How to select a Medicare Advantage plan. So step one, it's pretty simple, 4 steps. Step one, decide what diseases you and your family are going to have in the coming year. We can all do that. I don't know about you all, but I do that every year. I sit down. So decide what diseases you're going to have in the coming year. Step 2 is then, of course, find the best doctors and hospitals for those diseases, of course. Step 3 is pick the Medicare Advantage plan that includes those doctors and hospitals within their network. And then, of course, step 4, if there isn't such a plan, go back to step 1 and just, pick some new diseases. So we can all do that, right? So let's kind of make sure we all understand the difference between traditional Medicare versus Medicare Advantage. So traditional Medicare, I call it that because it's the Medicare that was started in 1965. It's the tradition of Medicare. Some call it original Medicare, but it's for the wonky folks here, it's Medicare Parts A and B, as you can see on this red, white, and blue Medicare card. Medicare Parts A and B. That's traditional Medicare. When I say traditional Medicare, that's what I'm referring to. And as you know, Part A is primarily hospital care that almost every American turning age 65 has access to, or having paid taxes all their life. And Part B, you pay a small premium, sometimes not so small premium, and then that covers most of your outpatient stuff. There's some there's some imperfections in this that we'll talk about, but that's basically traditional Part A and B Medicare. So it's kind of as simple as it sounded, right? There's all of us on the left. We because of our taxes and then this Part B premium, we get our Medicare card, and then Medicare directly pays physicians in hospitals on our behalf. That's traditional Medicare. The cartoon I made is pretty simple. There is more to it, of course, but simple and incredibly efficient, as I'll show you. Medicare Advantage is really a completely different animal. It's a completely different animal. So, and it's much more complicated, and therefore, as I'll show you, much less efficient. So there's us again on the left, still paying our taxes into Medicare, but Medicare now, you see, is no longer actually paying the doctors and hospitals. Instead, Medicare doesn't pay the doctors and hospitals at all in Medicare Advantage. No, Medicare pays an insurance company. And I've shown you I think those are the 6 largest insurance companies involved in Medicare Advantage. So So it's paying the insurance company a capitation, a flat dollar amount every month based on the number of people that are signed up for their plan, and some tweaks to that, some very important tweaks to that. But Medicare pays the insurance company a fixed dollar amount, and then the insurance companies pay the doctors and hospitals. So that money is to pay for the doctors and hospitals, but obviously the more they can get on the left side of this chart, and they have games to do that, then the more profitable they can be. And the less they can spend on actual healthcare on the right side of this chart, again, the more profitable they can be. That's sort of the business model. Cartoon's a little bit more complicated still beyond that because they don't actually contract with every doctor and hospital. Instead, they have doctors and hospitals that they want you to go to if you have to go somewhere, or they have doctors and hospitals that they won't pay for, or depending on your exact Medicare Advantage plan, they'll pay you significantly less. They'll pay a significantly smaller portion of that care. So it's a complicated mess, and complications are, not good. So they do things. They do things in Medicare Advantage that traditional Medicare simply doesn't do. Traditional Medicare just basically pays your bills for you. In Medicare Advantage, since their business model is to get in the way of your getting health care, they're allowed to use the tools that we've known and not loved from managed care, from HMOs, basically prior authorizations, where they're allowed to make you get permission to get one of those tests or to go to some doctors. So a variety of HMO style tools in Medicare Advantage. Traditional Medicare doesn't do that. They have, I think, 6 or so plastic surgeries that they require approval for because they want to make sure it's medical and not cosmetic, but they have, for the most part, they don't do it at all in traditional Medicare. Medicare Advantage does not cover the full breadth of Medicare doctors and hospitals around the country. They tend to be regional. They tend to have their own preferences. So if you're traveling, you may have difficulty getting coverage to see somebody for a non-emergency outside of your region. And within your region, they'll tell you, they want you to go to this doctor and not that doctor. Again, not something traditional Medicare does at all. Traditional Medicare, you have to deal with these crazy network issues. Because of this business model I spelled out to you, if you're actually very sick, you're not the person that they want to take care of, because then you're going to have a lot of claims expenses. It's going to cost more, and so they don't want you. But if you're really healthy, they're still going to get paid to take care of you. So yeah, they want you if you're healthy, and they're not so eager to have you if you're sick. So that's kind of the opposite of what you would want for an insurance model, right? Because of this complexity, as I'll show you in a moment, they have remarkably high overhead and annoyingly high profits in this system that all come from our public dollars, right? At the left side of this graph, or of this cartoon that I drew for you, there's still all of us. Just their money they don't print their money. We pay them. So their high overhead and profits come directly out of the premiums and taxes that we pay. And lastly, it's not entirely an up and up, forthright structure of organizations. They've been all kinds of accusations for fraud, aside from a variety of other things. So how does the business of Medicare Advantage work? Well, one thing that they do is fraud. It's one thing they do. And you'll frequently see examples of Medicare Advantage corporations that are making settlements with the federal government, or being for fraud, or being penalized for fraud. And you'll seldom, if ever, see a Medicare Advantage corporation admit that they were guilty. They'll just settle as part of the cost of doing business. They also, as I alluded to, they cherry pick. That's what that's called, when they're paid for sort of an average person, a little bit modified than that, but they're paid for the average person. So the healthiest among us, they have the lowest medical expenses, and they want you. That's called cherry picking. Lemon dropping, if you're particularly sick, they don't particularly see you as a profit. They see you as a liability. So I'll show you ways that they manage that. And then lastly, I showed you that on the left side of that cartoon a moment ago, they want to maximize how much money they get from the federal government to take care of you. And so one of the tricks for that is what's called upcoding, where they search out diagnoses that don't necessarily need to be treated. One of the ways they do that is Medicare Advantage companies send people to your house. In this data that came out a couple of weeks ago, you'll see that I think 19 or 18.6% of Medicare Advantage patients have had a single home visit from their Medicare Advantage company. So you join one of these outfits, and there's about a 20%, about a 1 in 5 chance that they're going to actually send somebody to your home for some home care. One visit. Traditional Medicare doesn't usually happen in traditional Medicare. You're seeing your doctor who's kind of making those assessments, but Medicare Advantage will send somebody to your house. One visit is very common in Medicare Advantage. Maybe that's a nice thing. But actual health care at your house, no, they don't do that so much. As a matter of fact, ongoing home care is much more common in traditional Medicare patients than it is in these Medicare Advantage firms. So they send somebody to your house. Why do they do that if they're not going to then hook you up to more home care? Well, they do that because once they're in your house, they examine you looking for specific diagnoses. They kind of come up with things that they can use to make you look sicker than you really are, so that they can justify getting paid more from the federal government, but they don't actually deliver the home care. So this new data shows that this is exactly what they've been doing, that they send somebody to your house to assess you, not to treat you, but just to assess you, apparently so that they can increase their finances. That's called upcoding. And just that one game that they play is worth billions of dollars. They upcode into this game and essentially, in my mind, rob our federal budget of billions of dollars every year by that one of many games. And they have never been able to generate savings. They always say, well, we're cheaper, we're less expensive. That's why you should like us. And that we'll get to that in a moment. But in terms of savings to the Medicare program, Medicare Advantage has never saved money for the Medicare program. And in fact, because of shenanigans like I just showed you, they actually cost more, not less. Plus, they're very expensive to operate. If you just look at the overhead. So any of my charts like this one that have numbers, as this one obviously does, at the bottom of your screen, if you get up and squint real close, you can see the public domain sort of reference. So this particular set of data is SEC filings from last year. And you'll see that the Medicare Advantage corporations operate with, let's say, a 15% overhead and profit combined. So that's 15% of the money that they get does not get spent on actual healthcare. It gets spent on the operations of the healthcare outfit, of the insurance company, basically. Is that a lot? Well, traditional Medicare doesn't do that. Traditional Medicare, which manages arguably the sickest of Medicare patients, has only a 2% overhead. So yeah, that's quite a bit of money that we're spending and that a public system wouldn't be doing. The Medicare Advantage companies do this because it's the best way they know to make money. If you just look gross margins, in most of the insurance world, insurance companies tend to make about $750, maybe $800. In Medicare Advantage, they make $1,700. So this is their biggest profit line, and that's why they fight tooth and nail against anything that would be disruptive to them, and that's why they advertise so rampantly on the television machines. Another one of their strategies is to say no. They just say no, right? Remember, traditional Medicare Parts A and B, the old-fashioned, one that most of the half of us love. Traditional Medicare doesn't do this. They don't prior authorize. They don't, just get the care that your doctor says you need. Medicare Advantage plans rampantly do that. So if you're in Medicare Advantage, there's a almost 100% chance that you can't get chemotherapy from your oncologist if you need it without getting the Medicare Advantage company to approve it, to say, no, not that drug. I like this drug better, they'll say. Or for any of these things you see on here, the Medicare Advantage company gets to evaluate this and decide which chemotherapy or which whatever they want you to have rather than your physician. So that, number one, changes how you're treated. That doesn't make any sense that they should be able to do that, but that changes how you're treated. And number two, it just delays care. I don't know how many stories I've heard of people who need to get their whatever care done, and their Medicare Advantage firm just is delaying approval. It adds weeks to care, and that can be annoying, and it can compromise your health. So, and they do more than just delay. The Office of Inspector General of the United States said that some is their cautious word, some beneficiaries don't even get the care that Medicare Advantage organizations, that's their acronym, MAOs, Medicare Advantage organizations, are required to provide. Some people don't even get the services that they were required to provide. And then more recently, just a few months ago, the American Hospital Association, speaking to the Department of Homeland Security, riddle me this, why, from the Department of Homeland Security, said that certain of these egregious health plan policies are just continuing left and right and really disrupting care. Some of the plans that strategies that they use are secret, and you can't find out what their rules are, and they're allowed to create their own secret. Medicare has its rules of what's covered and not, and they're public. And Medicare Advantage firms are allowed to make their own rules narrower than the ones that Medicare itself makes, and not tell you what those rules even are. And as a matter of fact, 18% of the claims that Medicare Advantage plans have denied would have been approved had you been in traditional Medicare. So if you're in Medicare Advantage, if you're in traditional Medicare, you're not going to get it denied because they don't do that kind of nonsense. If you're in Medicare Advantage, there's a good chance you'll be put through this approval process, and roughly 1 in 5 will be denied. And most of us don't have the wherewithal or skill or diligence or effort to appeal a denial. Usually when you appeal a denial, you can get to an approval, but hardly anybody does the appeal. So that's one lesson. So how do you pick a Medicare Advantage, an MA plan? Because they're not all the same. This 18% number I'm showing you is an average across the entire, that Medicare publishes that number. That 18% is across the entire spectrum of all Medicare Advantage firms. Well, when you look at an average, of course, some firms are going to be better and some are going to be worse. So you might want to know when you're shopping for an MA plan, does your plan that you're about to purchase, does that have an 18% denial rate? Does that have a 5% denial rate and it's not so bad? Does that have a 40% denial rate? You'd like to know that before you decide to lock into one of these. There's no way to know that. Medicare has this data, and Medicare Advantage firms have hamstrung Medicare so that it can't release this information. So Medicare knows which ones have the most egregious denial rates and is hamstrung from being able to tell us about that. Think of that. That's like if there were airplane crashes frequently and we weren't allowed to know which airline is crashing more than the other. It's just like that. I stole that from Alex Lawson of Social Security Works. But imagine if we knew that if the FAA knew that there's this one airline that's really going down all the time, and they said, hey, there's a bad airline out there, but we're not going to tell you which one. That's the situation you're in today with Medicare Advantage. You don't know which ones are doing better or worse. Maybe none of them are doing all that good. We don't have that information. And why do you want Medicare? Why do you want Medicare Advantage? Why do you want insurance? You want insurance so you can get healthcare, right? You want it so you can go get healthcare. Well, if you have traditional Medicare and Medigap, and you try to get healthcare, 12% of people in traditional Medicare with Medigap still say they have cost-related problems getting into care. That's actually a much better number than the people in Medicare Advantage. The people in MA overall have a much harder time getting healthcare than people in traditional Medicare. It's, of course, as you see for most metrics like this in the United States, it's not as egregious among white Americans. The ratio is about the same, but the pattern's not quite as bad. It's worse for Hispanics, and of course, it's America. It's worse for African Americans. These are folks who have chosen to go into Medicare Advantage often, and they can't even use their health care. This is incredibly important. Look at that number. So Congress, and I've met with several congressional folks about this kind of an issue about Medicare Advantage, and they often say, well, the Medicare Advantage plans, they tell us that, they have higher enrollment among African Americans, among low income, among other disenfranchised groups. So, and that's true. The disenfranchised groups in America are more likely to sign up for Medicare Advantage. And so Medicare Advantage firms brag about that and say, this is proof that we are the solution to the equity problems in America. I say that's exactly upside down. Congress hears that and thinks, yeah, hooray. So if you try to, point out the flaws in Medicare Advantage, Congress is reading that as you're attacking equity. No. I view this not as indicative of Medicare Advantage being the solution to equity. I view this as proof that the very people who most need help from the healthcare system are actually getting shunted into a worse product, look at that. A third of Black Americans in Medicare Advantage have financial difficulties accessing healthcare compared to a much lower rate for African Americans who are in traditional Medicare. So no, this isn't the solution. This is a symptom of the problem. This is an exacerbation of the problem. And indeed, they don't want you to go to the top tiered cancer centers. So if you look at the top tiered cancer centers for cancer surgery, if you have an appendectomy, probably any community hospital can take care of that. But if you need your part of your lung removed for lung cancer, and you need a lobectomy, or you need, part of your colon removed, your colectomy, or you need stomach removed, gastrectomy, or hopefully not the Whipple procedure. It's a pretty aggressive thing that you really want to have the experts do one of those things. You really want to go. You don't want to just go to the closest hospital. If you need something this intense, you want to go to a top-ranked cancer hospital if you can. And it turns out that people in Medicare Advantage are significantly less likely to go to a top-ranked cancer center. Why is this? Well, in part, it's because the Medicare Advantage companies don't want to attract all the people who are going to need one of these fancy procedures. They don't complain about it. Why isn't this top-ranked cancer hospital in my network? Well, because that's expensive. Why would we want to attract people who need that kind of care? And indeed, most people don't need that kind of care. And most people, to be honest with you, even though I've got these flaws I'm telling you about Medicare Advantage, most people that are in it don't run into these problems. They don't, because you're generally healthy. You're getting sort of generally healthy stuff, and sometimes, pretty expensive stuff. And generally, most people do okay. But when the rubber really hits the road, when you're in your last year of life and you really need to get things right, at that point, people are much more likely to return to traditional Medicare if they can, because they kind of learned that they have to. So in the last year of life, you're much more likely to say, I can't stand this Medicare Advantage firm. And the reason that people do that, among other reasons, the main reason is because the Medicare Advantage companies limit your ability to access specialized care when you really need it. And let me tell you, that's why you have insurance, because you need it when you really need it. They don't tell you this when you're going to sign up for a Medicare Advantage. And indeed, late last year, the Senate Committee on Finance looked at deceptive marketing practices in Medicare Advantage and said it's really rampant. Here's one of the mailings that came straight from the Senate Finance report. The Medicare Advantage companies send this out to people in the community and say, hey, you get this thing in the mail and it looks like a tax form, right? So you fill it out because you never ignore things that look like this. This is actually signing you up to go into Medicare Advantage. So you're being tricked into it. You're not doing it on purpose. So how do you find out what to do? Well, about a third of us rely on insurance agents. And I want to tell you, I know a few really, really good insurance agents who are really honest and really forthright. And there's one I know who I literally trust with my life. He used to be my trainer. I mean, I know him. I trust him literally with my life. There are some great people out there. But we all respond to the finances in front of us. And the Medicare Advantage, the insurance brokers who sell you a Medicare Advantage policy or sign you up for one get a $500 commission for that these days, probably more now. $500 for that. And it's a gift that keeps giving, right? Then the next year, if you don't change out of that plan, they might call you and say, hey, how's the whatever? And they probably won't review everything in detail with you, but just the fact that you haven't changed, the fact that you stay in the plan that they sold you means next year they get a commission too. And this keeps going for at least 10 years. So you're like a gravy train to them. So yeah, that's what do they get that if you ask them for advice and they sign you up for a Medigap? No, they don't. They don't. You're worth barely half as much to them if you opt into Medigap. So these aren't neutral bystanders. These are people who stand to they won't disclose this to you. These are people who stand to make a lot more money based on what decision you get. And then Part D, they don't make anything off of that, it's to speak of. So if you talk to your insurance agent, they probably, they walk you through the Medicare Advantage versus Medigap, that they'll do. When you tell them, when I help you with my Part D, they'll typically send you to medicare.gov and tell you it's really easy. You can do this. It's a great website. You can do that on your own. Well, guess what? You can do the same thing with Medicare Advantage and Medigap, but they don't want you to. They don't want you to because they've got some skin in this game. They want you to do what they're saying. But Part D, the process for picking Medigap is actually much simpler than the process for picking Medicare Part D plans. And they tell you to do it for Part D. You can do it for Medigap as well. It's actually easier. So it's not just their conflict of interest. Maybe that's what drives this problem. But the Senate Finance Committee or CMS, Medicare, CMS is the acronym for the Centers for Medicare and Medicaid Services. CMS should really be CMMS, but nobody wants to say all that. So it's CMS is the acronym for Medicare. And they did secret shopper calls last year on Medicare Advantage plans and reported that 80% of them were inaccurate or insufficient. My personal favorite, since I have a lot of background in the pharmacy universe, is this, that they said, hey, if your drug's not on the formulary, and that's when you're shopping for a Part D plan, you want to know, if your drug's not on the formulary, not to worry, silly. Don't worry your pretty little head there. Your doctor will just tell the plan, and the plan will just add the drug, and you don't have to even worry. That's patently not true. So, okay, so why do people sign up for Medicare Advantage if it's so awful as I was describing? And I thought this PNHP board member, Jessica Shore-Sachs, said it the best. She said, despite all of this, the low premiums and perks may still be attractive to people who aren't yet sick. The situation changes when they develop an illness. So that's quite a bit different. So here's the rub, right? Traditional Medicare is far from perfect, as I mentioned. So it has a 20% outpatient coinsurance, meaning of all your outpatient stuff, you got to pay 20% of that. They don't pay 100%. If it's one doctor visit, doctor visit's $100 and your coinsurance is $20 and you do that once a year, most of us can deal with that. But if you're sick and you're going to, 3 doctors a week or 2 doctors a week, and the doctor visits aren't 100, they're $400, and you're paying 20% of that over a few months, that's bankrupting. That's bankrupting. This 20% coinsurance and traditional Medicare, you got to have a strategy of what you're going to do for that, because that's bankrupting. If you're hospitalized, the deductible for hospitalizations for Medicare, traditional Medicare, $1,600. And some people are hospitalized 2-3 times a year when they're sick. Again, bankrupting. And the sky's the limit on this, right? The sky's the limit on this. So these numbers don't have any maximum on it. Plus, of course, in traditional Medicare, you got to pay a premium for Part B, got to pay a premium for Part D, the drug benefit, and you got to pay a premium for a Medigap plan. The Medigap plan, which we'll talk about more in a moment, picks up those co-insurances and the deductible and a lot of stuff. So with a Medigap plan, you're protected. So if you're in traditional Medicare, you want to be sure you have some version of a Medigap plan. So really, you have 3 choices. You could not get a Medigap plan, just have traditional Medicare and do nothing else. And like I said, you've got serious exposure to bankruptcy if you do that. Don't do that. Don't do that. Your second choice is to leave traditional Medicare and sign up for Advantage, so-called Advantage. So that's one of your choices. And then the third choice, of course, is to purchase Medigap. Stay in traditional Medicare and purchase Medigap. Maybe. What you may not know is that you may not be able to get Medigap. If you've been in Medicare for more than 6 to 12 months, you may not be able to get Medigap. So when you first go into Medicare, for the first 6 months that you're in Part B, if you want to buy a Medigap policy, the Medigap insurance companies are legally obliged to sell you a policy at the same price they would sell it to anybody else in your community. And that's extended to 12 months of protection. So there's no issue of pre-existing conditions for the first 6 to 12 months that you're in Medicare with buying a Medigap policy. But after 12 months, the Medigap plans can send you a health survey questionnaire. You're in Medicare Advantage for 13 months, then you get the cancer, and you find out that they won't let you go to the doctors and hospital that you want to go to. You're thinking, well, I remember that talk. I heard about this. I'm getting out of Medicare Advantage, I'm going back to regular Medicare, and I'll just buy one of those Medigap policies. Well, if that's at 11 months in Medicare, yeah, you can get out of Medicare Advantage and go buy a Medigap policy and be covered. If that's at 13 months, Well, when you try to go buy your Medigap policy, the Medigap policy company is allowed to send you a health survey questionnaire. It's allowed to look at your claims data. It's allowed to say, oh, no, 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 this person has cancer. We're not going to sell them a Part B. We're not going to send them a Medigap policy. So the time when you most need it is the time that you might find yourself trapped in Medicare Advantage. And not very many people realize that they're making that decision, that they're exposing themselves to this. So there is a way out. I just read about last week. If you're in Medicare Advantage and you're running into, gee, I can't get out of Medicare Advantage, because I can't buy a Medigap, and you want to do something extreme, some insurance agents are actually saying if you're really trapped, you can go back to getting your guaranteed issue if you move away from the geography that your Medicare Advantage plan service area has. So move out of state. You can't just change your mailing address. You have to actually move, and then that triggers a reactivation of your ability to be protected. So some people actually recommend. I do not recommend that. So why do people sign up for this? Well, let's walk through it maybe side by side. Medigap Plan G. There's a few different Medigap plans, but for the most part nowadays, Plan G is the one when you go looking for it. So the benefits. Medigap plans don't add any benefits beyond what's currently in traditional Medicare. Medigap doesn't give you eyeglasses. Medigap doesn't give you dentistry. Medigap doesn't even give you pharmacy. Medigap only takes care of the copays and deductibles. Medicare Advantage, MA, which is also called Medicare Part C, Medicare Advantage often includes additional benefits, like almost all of them now include a pharmacy benefit, which may or may not include the drugs you want, but a pharmacy benefit and hearing and all these other kinds of things. Medigap, so that's Medicare Advantage wins. They give you extra stuff. Medigap eliminates your out-of-pocket expenses after you've used up the Part B deductible. Hooray for that. Medicare Advantage doesn't necessarily do that. You can still have copays and deductibles. Typically, you do have copays and deductibles in Medicare Advantage. And indeed, they don't tell you this, unless you look for it. And you have to look for it. It is on the Medicare website. If you go shopping on your own, the Medicare Advantage plans have up to a $12,450 out-of-pocket maximum. How many of us can afford $12,450 out of pocket? Medicare Advantage, you're exposed to that. Traditional Medicare with Medigap, no, zero out of pocket after you've gone through the $226 deductible. So I'm sorry, that piece, Medigap plans are hands down and away the big winner if you buy Medigap. So utilization management, Medigaps don't do that. Traditional Medicare doesn't do that, except for, as I said, for a handful of things. Medicare Advantage, it's rampant. They do it all over the place, all this kind of shenanigans that just delay and deny your health care. So again, traditional Medicare with a supplement wins. Networks, right? Medigap doesn't change your network. So traditional Medicare covers, I think 89% of physicians of adult medicine physicians in the United States accept payment from traditional Medicare all over the country. You're in traditional Medicare with Medigap, you still have access to the entire country. You can go if you're living in Seattle, you're taking 2 months in Florida, you can still get almost any doctor in Florida still takes that, and you can get healthcare wherever you want. Whereas in Medicare Advantage, no, you kind of have to go the in-network doctors and hospitals unless it's really an emergency. So the lists are much more variable, and the doctors come in and out of those networks. So it's tough. So again, Medigap is the winner. But then there's the monthly premium piece. So the monthly premium for Plan G, which is the one that I was suggesting or looking at here, is about $200 a month. And then that's on top of still paying $165 a month for Part B, which you usually have to do if you're in traditional Medicare or Medicare Advantage. And then $32 is the average for a Part D drug benefit premium. So if you're in Medigap, you're probably looking, if you choose Medigap, you're probably looking at something nearly $5,000 per year in premiums, but then just a $226 deductible and nothing more. So under $5,000 a year total healthcare costs. Medicare Advantage, you can usually join on average for $15 a month across the United States. And where I live in Missouri, the average is $0. There's an awful lot of free Medicare Advantage plans, and those come with a drug benefit and all the other things. So it's a trade-off. right? You can join Medicare Advantage for much less money than you can buy Medigap. So yeah, when you look at just the upfront expense, Medicare Advantage is the winner. And so it's really a decision. It's not a slam dunk. I mean, the key difference is if you're in traditional Medicare with Medigap, you're looking at having to pay that premium of about $5,000. And if you're in Medicare Advantage, it's a significantly smaller thing. So people think that they'll start with Medicare Advantage because it's so much cheaper up front, and then go back to traditional Medicare with Medigap if they have to, not realizing that they're probably trapped. So that free or nearly free side of MA makes it nearly irresistible. So for patients, it's like, affordable, unlike Medigap, until we get particularly sick. They like the extra benefits until they realize how sometimes they're the right benefits, but yeah, it's like the most minimal dental care. If you get dental coverage, it's barely the 2 tooth cleaning. It's not any major dental work. It's a little bit of dentistry. And the same thing, it's not the extra benefits. Most people don't use but a tiny fraction of them. So it's something, but that's very tempting. And I'd kind of bemoaned if they won't let you go to this doctor or that doctor, these networks. Well, most of us nowadays who've had employer insurance for a long time are adapted to the notion that insurance companies say use this doctor and not that doctor. Older Americans are outraged when you tell them, but we should all be outraged. Most of us, however, have adapted to that and aren't as horrified by what I think should horrify us. And like I said, you want to try to shop and find the better Medicare Advantage plan. Good luck with that. You can't really do that. There's a star rating on the Medicare CMS government website that's supposed to help you with that, but that's been looked at a gazillion times, and that star rating doesn't tell you anything about how likely they are to deny your health care, how likely you are to live or die because of joining that plan. And indeed, there are higher death rates in some of these Medicare Advantage plans based on what they do. And the star ratings don't help you differentiate one from the other. So you're kind of trapped. It looks attractive, but you don't have any good way to design it. Medicare Advantage corporations, it's not nearly irresistible. They love it. They love the profits I showed you. And then they also live by this 80-20 rule, where they know that 80% of their spending is done by only 20% of patients, and probably 90% by 10%. So they know that. They know that means, that they have to do things to keep that 80% bulk of patients happy. Sure, you want your appendectomy in Boise instead of in Seattle? We don't care. Go wherever you want. I'm just making that up. So they want to keep the 80% who don't have very much expense happy. And then when the 20% or the top 5% of expense patients complain that their doctor isn't in network, what are you going to do as a patient? You're going to say, if you don't put my doctor in network, I'm going to quit. I'm going to go to a different plan. Medicare Advantage company says, hooray, you're too expensive, So they don't care about that. So it's a pretty irresistible business model to them. And legislators, they hear over and over again from Medicare Advantage companies that this is saving the country money, despite everybody who's looked at this saying that's not true. There's this independent thing called MedPAC that Congress created to give them guidance about Medicare's performance. And every year, for as far back as I've looked, MedPAC, this government, quasi-government, I don't know what you call it exactly, agency, very well respected, consistently says, no, they're stealing from us almost. They're overcharging, overbilling. It's not a good model here. They've gotten these messages over and over and over again, but for some reason they choose to believe the message from the insurance companies that, oh no, look how great we are. That's just ridiculous. And they see Americans flocking into Medicare Advantage. And indeed, as you probably know, this year we crossed the Rubicon, and now it's like 51% of people in Medicare are in Medicare Advantage. And they just think that means that seniors are saying, people with disabilities are saying, this is a great thing. They see the growth. The 50% market share is growth is proof that it's a great thing. And that's not it at all. It's not that their ice cream is any better. People aren't picking that ice cream because it's better. They're picking it because it's free ice cream. That's Don Berwick's line that I really loved. So it's a financial decision that you're making. It's not that you've decided Medicare Advantage is better. It's a financial decision. Congress doesn't quite recognize that, and they see people going into it as proof that it's such a good thing. And then the thing that really just makes me furious is that There so many people in Congress are hearing from Medicare Advantage firms that they are the solution to equity. When I hope I've convinced you that no, they are the problem. They are one of the problems with equity. So how do we resist the irresistible? First thing is, it's ridiculous that Medicare has these premiums and that Medicare Advantage doesn't. It's ridiculous that there's no out-of-pocket maximum in Medicare unless you buy a Medigap policy. If you don't buy a Medigap policy, you can be bankrupted in traditional Medicare, as I said. Well, that's not fair. We need a level playing field. So the first thing is introduce a very low or $0 out-of-pocket maximum in traditional Medicare. Traditional Medicare should have a $0 or certainly very low out-of-pocket maximum, just like Medicare Advantage has an out-of-pocket maximum. We need that too, only much lower than that. And then, of course, add in the missing benefits that traditional Medicare doesn't have that seem to make Medicare Advantage also more attractive. So level the playing field. Helps individuals resist the otherwise irresistible. Most people, unless we do that, unless we fix that, most people are still stranded and trapped in Medicare Advantage. Second thing we need to do to resist the irresistible is expose some of this stuff I was telling you, expose the profiteering, expose the delays and denials and problems, and for crying out loud, publicly report the individual plans so that we know which airline is crashing more. And then lastly, don't stop there, of course. This is just things we should do along the road towards getting us sign the bills, get your legislators to sign the bill and co-sponsor the real answer here, which is Medicare for everybody in Congress. So good news, PNHP has been feverishly working on more information about this, and we're in the next few weeks, but hopefully by the end of September, we're going to have a new report that's going to sort of put all the finances of this together. And it'll show you a comparison of what the Medicare Advantage firms are taking from us and what we could have instead. We can actually show you side by side. Here's how much we're being robbed almost by Medicare Advantage companies, and if we took that back, here's how much we could really improve traditional Medicare. Very last thing for me to say to you is take some action. We're trying to do a survey of people that are in Medicare and Medicare Advantage. So take your little smartphone and point it at that QR code and then save that link to fill out our survey. Take your phone and then point to this other link to sign our petition so that you can make your voice heard against this stuff. And then lastly, there's a whole lot more tools. So if you take a moment and find a little QR code on all those and then save those links. So I'll leave that up for a moment and then I'll stop. So I need to turn off my camera for just a minute.
Thank you, Ed. That was really outstanding. I want to let people know who registered that you will receive an email from Pizarra with the link to this webinar if you want it and you want to share it with other people. And as I said to you earlier, it will also be on the Pizarra website very soon. So Ed, that was terrific. And I was going to ask you what you think about the leveling the playing field strategy, and you pulled the rug out from under me. I just think that that's exactly where Pizarra is going, is that we understand that most people are choosing Medicare Advantage because it is financially, so many retirees simply don't have enough income to pick up the expenses of traditional Medicare. So we really need to fight to level the playing field. And that's what we're working on. And that's what we're hoping will be taken up as the call all across the country. So remember, you've done a great job there. I see now 21 questions on the Q&A function. You all are doing great. Lisa Decker, who is the outreach vice president, one of two outreach vice presidents for Pizarra, is going to handle the Q&A, and we'll devote about, even up to 30 minutes for Q&A, and then we'll close. Ed, great job. You did a wonderful job. Thank you. Take it away, Lisa. Be sure you unmute, Lisa. Okay, go for it.
Yeah, hi, everybody. We had some terrific questions. I will start posing them here to Ed. And again, I remind everybody if they want to add another question, go to the bottom of your screen and put them in the Q&A. Okay, well, let me start here. Right off the bat, someone asked if you move to another state, would you have to move to a guarantee issue state to actually change the rules for yourself, or would you just have to change states?
Yeah, if you move outside so there's regular open enrollment periods, they're 2 or 3 months every year where you can make changes. But then there's also this thing called a special enrollment period. And there's a variety of things that trigger that. If you have a major change in some life circumstance, there's a list of these things. But one of which is if you move outside of your Medicare Advantage plan's service area, then that triggers what's called a special enrollment period, and that gives you guaranteed issue again. That gives you guaranteed issue. So that is one way. It's pretty drastic way, but yeah, if you move out of their service area, you have another window of guaranteed issue.
Okay, another question. Someone asks, are Medicare Advantage plans required to cover skilled nursing and long-term rehab?
I'm not actually sure of the answer, so I'm not gonna. I think I know the answer, but I don't know if you or Robbie, know the answer. I'm not certain of the answer. I'm not gonna say.
Lisa, our experience is that they are required to cover skilled nursing when someone is coming out of the hospital for rehab, but they set a limit on the amount of time that you can be in skilled nursing, usually about 10 days. And we recently had an article in the Retiree Advocate about someone's experience with the limits that were set by their Medicare Advantage plan. They have some kind of process, I don't know if it's AI or what it is, to say this is the only amount of time you should have. But yeah, if it's for rehab and it's something that the hospital and doctors have called for, they have to cover it. But they can then decide, okay, you've had enough time, you're ready to go home, you need to go home, even if you're not. And that was the situation with the person who wrote the article in the Retiree Advocate.
Okay. Let's see. Another one is pretty broad, but it sounds like a good question. How do hospitals fit in the picture? I don't know.
Hospitals are increasingly extracting themselves from this picture. So we're starting to see a wave of hospitals that are saying, I can't participate in this anymore because they're just fed up with having the services get denied. They're fed up with having people discharged and not being able to get into the kind of care that they think they need. So hospitals are increasingly unhappy about this. So Medicare Advantage companies can tell you decide which hospitals they want to contract with, and they don't contract with all hospitals. They're very selective about that because they try to get certain rates, and they don't want the hospitals in general that are going to attract the sickest of patients. That's, as I showed you, opposite their business model. So up until recently, we were seeing the problem with narrow hospital networks in Medicare Advantage firms being driven by the Medicare Advantage organizations refusing to contract with hospitals. And now the last year or two, we're seeing that sort of escalated hyperbolically, where now the hospitals themselves are saying, we had a contract and we're seriously thinking of pulling out because we're sick of working with these outfits.
Okay, thank you. Here's one that just came up. And this is a term that we haven't used in this webinar, but we've done it before. The question is, what about the ACO REACH program that seems to be privatizing traditional Medicare?
Yeah, so Medicare Advantage is, as you saw, sort of pilfering the Medicare trust fund, and that means it's taking the money off from Medicare and putting it into the coffers of the investment community. The investment community figured out a few years ago, I don't know, under President Trump, that meant that there was another half of Medicare. At the time, it was more like 60% of Medicare. That was traditional Medicare, was not in Medicare Advantage, and it was largely off limits to the investment community. They didn't have a good way to get into it. So under President Trump, the investment community, I believe, persuaded, and I believe there's good reason to believe, persuaded the federal government to create this thing called ACO REACH, which lets the investment community do very similar things, not identical, but very similar things to what Medicare Advantage companies do. So you can be in traditional Medicare and have Medigap, so you're paying up for it. You can be in there and have made that decision because you don't want somebody making extra profit off of you. You don't want somebody telling you this doctor, not that doctor. You can be in that. And then unknown to you, the Medicare program can assign you to something called an ACO REACH. Now, they do that based on who your primary care doctor has been. And if your primary care doctor is in one of these ACO REACH outfits, then Medicare assigns you to that ACO REACH. That ACO REACH then has the same fundamental business drivers that Medicare Advantage has, and that the ACO REACH is capitated in a similar way to how Medicare Advantage is. So they're paid the ACO REACH. And so instead of Medicare paying your doctor for you without ACO REACH, now all of a sudden Medicare is paying an ACO REACH, who then pays your doctor. And it's the same drill, less care, more profit. Well, that's the opposite of what we want from a public health system. So it's bad in my mind. And the profit opportunities in ACO REACH are even more egregious than they are in Medicare Advantage. So traditional Medicare has a 2% overhead, as I showed you. The Medicare Advantage insurance companies have about 15% overhead. And the way the ACO REACH contracts are written up, they can get 25% of their revenues that they can retain. And if they really push it, they could go significantly higher than that, but it's almost impossible to push it that hard. But they can keep even more of our money than the Medicare Advantage companies have. So it's a terrible system. The good news about that particular system is that it's going to end in 2026. So that model, something that was on track to take over most of traditional Medicare because of the advocacy work. I believe because of the advocacy work of great outfits like Pissarra, is not going to be extended beyond 2026 and is not going to grow beyond there. I forget the exact number. It's less than 2 million people instead of the 30 million they were on track for. So that's the good news. The bad news is there's a whole bunch of similar nonsense coming down the pike from the Innovation Center that we're learning about. So it's not over. This is far from over.
Okay, thank you. Here's another one. Question is, do pharmacy middlemen deny medications to increase profits, kind of like MA does?
Not exactly, because remember, the pharmacy middlemen, by that I think you mean pharmacy benefit managers, they typically only make money if you fill a drug. If you actually don't fill a drug, they're not gonna, they keep a percentage of that, either through, per prescription, or a percentage of the rebate, or all of the rebate. But if you're actually not filling a prescription, there's no money getting pumped into the system for the pharmacy benefit manager or the pharmacy middleman, if you like, to keep. So they don't actually want you to not fill drugs. That they want the opposite. They want the opposite. But they're very thoughtful about which drug you should fill, right? Because some drugs have really large opportunities for the PBM to make a profit, and some drugs don't actually have any opportunity for them to make much of a profit. So your doctor will prescribe you drug X because your doctor and you have sat down and thought about the benefits and risks and yada, yada, all the stuff. And they've come to a decision about what's the right drug for you in this circumstance. It's not as clean a process as you might hope, but they made a decision, right? You and your doctor made a decision. And then the PBM, the pharmacy benefit manager, may say, well, we're not going to pay for that drug. there's drug X. Okay, you and your doctor think that's the best one for you. You can go buy that retail if you want. Sure, it's $20,000, but go buy that. We're not saying you can't get it. You've got a prescription. Go to the pharmacy and mortgage your house and get the drug. Of course not. But not to worry. Here's this other drug that, yeah, we will have, your insurance will cover that. Of course, that other drug might be only $15,000, or it might be $32,000. And the PBM might be able to retain a chunk of that, a bigger chunk of that. So it literally might be a $32,000 drug instead of a $20,000 drug, with the PBM able to retain many thousands of dollars as a result of guiding you towards this other drug. Now, in general, the PBMs will say that's not what we do. They'll say we guide you from the $20,000 drug to the $15,000 drug, and then we keep a portion of that. I don't know. That stuff's like a black box. It's you don't get to see that. It's hidden. It's proprietary. So they don't. So they can say no to specific drugs, but in general, they do want to come up with something for you to take. Their choice, not yours and your doctor's.
Okay, thank you. This one, I don't know if you have the statistics for this, but I know you talked about it, but someone asked, do the poor, low-income folks, do they sign up for Medicare Advantage because it costs less and greater numbers?
Yeah, that's the only reason. I mean, that's if you're living on $25,000 a year, and you have some idiot like me saying spend $5,000 a year on a Part B and Part G and Part D, premium. No, you're not going to do that. You can't do that. You'll be one of the 10% of people in Medicare who don't have any solution to the co-pays and deductibles. So yeah, and then you see on the TV machine that you can get into Medicare Advantage for free or for $15 a month, get some drug benefit, get some hospital care, not be at as bad of a risk of bankruptcy, as long as you want to stay inside their network. Then they're signing up because it's a financial decision, not because it's a nicer thing, but for the financial decision. It's a pretty straightforward decision, which it goes back to Robbie's point of if you want to go into Medicare Advantage, Godspeed, go do that, even though it's actually draining the money from the federal government, But for crying out loud, those two programs, Medicare, traditional Medicare, and Medicare Advantage, should at least not be a financial decision for the individual. And if it is one, well, remember, Medicare Advantage is more expensive for the federal government. So if it is a financial decision, the federal government should make it cheaper for you to stay in traditional Medicare and get Medigap, not more expensive. That's completely upside down. But yes, short answer, yes. The reason that lower income folks go into Medicare Advantage is because the system is not a level playing field, and it's the only choice they can make short term, despite the long term exposure to even worse bankruptcy.
And just cross your fingers that you don't get sick.
Nobody gets out alive, so we're all going to get sick one day.
All right.
Lisa, can I just add one thing to that?
Mhm.
It's also an issue of equity for people that are in Medicare, traditional Medicare, because the premiums that we pay are going to pay for not just the additional benefits that the Medicare Advantage plans are providing, but for all the profit that the Medicare Advantage plans are taking. So it's not only that people should have a choice regardless of what their income is, but it needs to be an equitable system. And it's not going to be equitable as long as people have to make the choice to choose Medicare Advantage because they don't have the money to be able to afford traditional Medicare.
Yeah, that's right. That's exactly right.
Okay, thank you. Here's one. It's kind of maybe or maybe not that you'll be able to answer this, but I know that a lot of people use USAA insurance, and someone asked, is that any better than some of these other plans that we mentioned in MA?
So two parts to the answer. First is I have no idea, because I just don't know. But secondly, I'll bet most of us don't have any idea, because the kind of information you want to select amongst these options is not publicly released. Some of the airlines are crashing planes left and right, and the FAA is not telling us which airline that is. So I don't know the answer, and I suspect most of us don't know the answer to that. Interestingly, we've heard informal reports that people who work in Medicare, inside Medicare, tell their families which Medicare Advantage plans to use or not use, because they know they have the data, but they're just not allowed to share it publicly.
Well, I've almost come to all the ones that I think we can do. Let's see here, just a second. Okay, I'm going to read this one. How do we know how many people are put into Medicare Advantage because their employer makes that their only choice when they retire?
Yeah, I don't have a number on that, but I do know it's a rapidly growing phenomenon. So if you think about what are the threats to Medicare today, and since I'm saying Medicare Advantage is one of those threats, look at how they've been growing. I mean, they've been growing up until now, primarily retail is how I think of it, onesies, twosies, advertising on television to get you to be persuaded individually to make that choice. And then a little bit worse by doing it sort of really misleadingly, fraudulently, according to the Senate Finance Report, sort of chicanery and trickery. But that's the sort of retail approach. That we're seeing more and more that Medicare Advantage firms are moving into the wholesale approach of having employers and other groups move en bloc into Medicare Advantage for terrible reasons. So yeah, I don't have a number to tell you how much it is, but I'm of the belief that it's growing rapidly, and that's going to be the next wave of how they get to having everybody in the country.
Lisa, can I take a minute on that one?
Sure.
We have seen this play out with the retirees in New York City. 250,000 of them are the mayor, along with, unfortunately, some of the union leadership, are trying to force all of them into Aetna, and are saying, your only choice is to go into Aetna, or you can go out on your own and make your own choice. And we ran into that in Washington State too, where there was an effort to do that, and we were able to stop it. And the 250,000, or at least a bunch of those folks, are fighting it really hard in New York City. And we're seeing that it's happening a lot to public employees. And we're seeing a lot of resistance to that from public employees, from being forced into Medicare Advantage. So it is, as Ed said, a phenomenon. I don't know exactly how it's playing out with private employers, but it is a phenomenon with public employers.
Okay, and here's one. I think you pretty much answered this one, but just in case this person didn't hear that, you said that the ACO REACH program will end by 2026. Our understanding is that CMS recently stated that they want all Medicare patients and providers in an ACO by 2030, and ask, would you please clarify?
Yeah, I agree that this is sort of confusing language, but CMMI, the Center for Medicare Innovation, which is a sort of part of CMS, Center for Medicare's and Medicaid Services, announced several years ago that their intent was to have everybody from traditional Medicare in a value-based model. And at the time, ACO REACH had a different name. It was direct contracting entities, but it was one of several models that they were trying to put people into. It looked like it was on track to be the model to take over all of traditional Medicare, but there were several others. So ACOs are sort of a broader, not quite as it's a different model, but it is a value-based model, so to speak, using their words. It's a prepaid model. ACO REACH is the more egregious form of that, if you ask me. But then there's other ways too. There's other initiatives that the Center for Medicare and Medicaid, the Center for Medicare Innovation is working on. They just released another one last week. And so their plan is to have their stated plan is unchanged from a few years ago, that they want to have 100% of people in traditional Medicare into one of these value-based, their words, models, of which ACO REACH is one example. But it doesn't have to be ACO REACH. So they didn't change their tune at all. about having 100% in something, and they didn't change their tune that I've been able to see about having ACO REACH itself is the one of many models, having that particular model end in 2026. So these things sound like they're different, but they're actually, those statements are consistent with each other. I hope that was as clearer than mud.
And the term value-based is used by them, but it is pretty misleading, right?
Yeah, it's terrible language, and I should spend more time thinking about what else to call it.
Okay.
Value for whom, I guess, is the question. Value for Wall Street.
I think, hold on, there might be one new one here. I will say that there were at least 1 or 2 questions that really applied to Washington State, and I don't think it's fair to ask, because I think we'll try to get back to those folks though and see if we can answer it. Let's see. Okay. Another one, people in New York City. So he's referring to this being forced are retirees. Are there other working people who are being forced to go into, I imagine, MA or, yeah.
Well, employers are making that choice to push people in. So all sorts of retiree groups are being shifted into there. So yes, New York is not. I wish it was just New York, but no, it's all over the country.
Okay, great. Well, I think that's all that.
I see one I want to ask. We have one coming from one of the people fighting in New York State. Can Dr. Weisbart explain how PNHP works with and fits in the growing movement among grassroots organizations like Be a Hero and the Nurses Campaign for Health Care Over Profits? And is there a National House Organizing Center for the fight to protect and expand Social Security and protect traditional Medicare?
Well, Social Security is sort of, I would say, look to Social Security Works as the sort of the leaders on that stuff, and Public Citizen does a lot of good work on that too. PNHP, frankly, Social Security is really, really important to us, but it's a little bit off scope for so we don't have a lot of resource on that. On the Medicare stuff, yeah, I mean, our website is like, huge clearinghouse for that. So go to the PNHP website, pnhp.org, go to protectmedicare.org. That's our other site that has a lot of information. But yeah.
I want to say that Pizarra really understands that we can't win this battle just by being organized in Washington. And we are really encouraging both other grassroots organizations around the country that we're in touch with, and also national organizations like, PNHP does great work. Be a Hero is doing great work. Social Security Works is doing great work. At some point, we hope we can build something where we work together and coordinate, because this is a massive battle, and we're taking on some of the most powerful corporations in the capitalist system in this country. These insurance companies, United Health, Cigna, and others are among the top 10 corporations in terms of revenue in this country. And so it's going to take a lot to be able to turn the tide on this, because they're making goo gobs of money off of Medicare and off of Medicaid as well. So we hope that national movement can be built, and we will do everything we can to help make it happen. Ed, do you have any further thoughts on that?
Yeah, I think goo gobs of money is one of those MBA terms. I didn't know you had an MBA. It's yeah. But yeah, this is a complex, anything in life, when you're dealing with a complex problem, there isn't going to be a simple solution. We always wish there were, because it's so much easier to understand a simple solution. But this is a big, complex problem, and there's so many parts to it. I mean, I think one of the biggest root issues is how fragile and damaged our democracy has gotten. So, I think one of my favorite examples here is somebody told me that they sing in a choir, and there's the sopranos, altos, tenors, and basses, and good choral music has all 4 voices singing, but seldom at the same time. So if you're a soprano, you don't have to sing all the parts. You can't sing the bass part. If you're a bass, you don't sing the tenor's part. So we all need to find our voices, find the part of this complex work that we're comfortable doing, that we want to focus on. Some of that's inside Congress, some of that's outside of Congress, some of that's, in the cities, some of that's in academia, some of that's in the media. There's so much to do. There's no shortage of things. So if you're an alto, sing the alto part and be comfortable and sing the best alto part you can, and don't feel like you have to do the parts that you're not doing, because it all has to be done.
I just a couple of more things from the Q&A, Lisa, if I can. One, someone asked, what is the acronym PSARA? And it stands for Puget Sound Advocates for Retirement Action. Spencer Cairns from Be a Hero organizer, says, feel free to add that PSARA is doing great work, and so are the New York City retirees. And of course, so is PNHP. And then our former legislator from New Hampshire, who is now a PSARA member, as is Ed, said, has anyone collected numbers on how many people on Medicare Advantage that want to switch to traditional but are not able due to pre-existing conditions? And I don't think there's any way to collect that data. Ed, is that right?
Well, there is a way to collect it, but it would be pretty expensive, and it doesn't. That data doesn't exist today. But it seems pretty obvious when we know that the data shows the sicker you are, the more you go into it. We know that people who have the least financial resources are the ones who choose it. So there's all sorts of reasons to know that the number is there and it's big. I haven't seen anybody put a number on how big, but I think it's big. But you're right to point out, it'd be good to know that, of the 30 million people, that it's 20 that would leave tomorrow if you fix this. And we don't know the answer to that. It's a really interesting question, though.
There's someone here who asked us to clarify what is value-based purchasing. Do you want to take a run at that, Ed, or you want me to? What would you like to talk to your understanding of what value-based purchasing is?
You can go for it, Robbie.
All right. So the concept of value-based purchasing is that, are you getting value, medical value, from the purchases that are being made? So what they're doing with ACO REACH and other ACOs is they're creating limited liability corporations that are supposed to evaluate whether the cost of what is being done is worth what it's delivering in terms of healthcare. And the more they find that it is not value-based, that is, that it's not providing, health or healthcare or health services that provide value compared to the cost, then they can step in and say, no, we don't think that this is a good thing to do. And they can recommend that to the whoever the medical provider is. So it's an outside group evaluating the decisions that medical providers are making and deciding whether they're of value. And they have an interest in finding it's not, because they get more money if they find that it's not of value. And that's what that value-based purchasing is. Ed, you think that was a fair explanation of it?
Yeah, that's pretty fair.
All right. Lisa, you're ready to call it quits on the Q&A?
I think so. There's one that might sort of wrap it up a little bit. Somebody asking about what your thoughts would be on universal health care, because especially businesses would be supportive because they wouldn't have to pay insurance for employees. So, I don't know what you think.
That's the only thing I think about all day and all night if I'm not sleeping, is that we need to do that. I'm a physician. I've seen, I don't know how many patients who couldn't afford to get the healthcare that they needed. Diabetics that take their insulin every third day instead of every day or twice a day because that's all they can afford. People who have an impending stroke who decide to not get their angiogram or whatever, and not get their procedure because they can't afford it. It's criminal. It's, when you're letting people die and you don't have to there should be a law against that. So it may not actually be criminal, but it should be darn well criminal. It's murder that we let that happen in a country with as many resources as ours. So yeah, I'm passionate about the idea that everybody should have access to unfettered access to healthcare that they need without risking bankruptcy, and have it be the care that they want to get. And aside from it being the right thing to do, it makes great sense for the business community, as the questioner was saying, because it's an increasing unpredictable expense for their business. They have to spend time on it. Instead of designing the best widget, they have to have an entire human resource department to renegotiate their health benefit contracts. Their health benefit contracts often cost more than the hourly wage does for their employees. They have to provide it to compete to stay in business. It's I know a manufacturer in Canada that wants to relocate to the United States because that's where all their customers are, and they actually get their raw materials from the United States. So they're shipping materials up to Canada, assembling them in a factory in Canada, and then shipping the product back to the United States where their customers are. They want to move to the United States because they don't want to pay all that ridiculous shipping, but they can't, because the arithmetic on how much more their healthcare benefit would cost for their employees is worse than what they would save by getting rid of this crazy transportation fee that they have to pay. So yeah, it would be great for business. It would give them a predictable, they wouldn't get a free ride because they can't just go from today paying for what they pay and then tomorrow not paying for. There have to be a fair way to transition that. But they would know what it is. It would be a predictable amount. It would be significantly less than what they pay today, and then they would stop having to manage this. They could work on, in labor, unions could negotiate wages and working conditions and the things that matter to them, rather than having to not advocate for their wages as aggressively as they want to, because they have to advocate for healthcare, or their union membership is going to die if they get a bad healthcare deal. So it's craziness.
There, yes.
Yeah, short answer, yes. Sorry.
Thank you. Thank you, Ed. You were wonderful. Thank you for doing this for us tonight. We'll probably get back to you, and thank you for being a Pizarra member. And want to thank everyone who is still on here for coming to this webinar. As I said, you'll be receiving a link to this webinar in an email with that link. Please take a look at our website, our new improved website, pizarra.org, psara.org. We like to consider our newsletter the best non-award winning newsletter in the country. Take a look at our newsletters that are on the website and think about becoming a member, paying $20 a year, and being able to receive it on a monthly basis. Thank you, everyone. Thank you, Lisa. You did a great job. And good night to all of you. Thank you.